Welcome to our webinar titled Living with Chemotherapy Induced Peripheral Neuropathy. My name is Lee Clark. Thank you for joining us today, and I'll be moderating the presentation. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you're unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. The program today will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window, and we'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Our expert today is Donna Hammond. She is a professor of anesthesia, neuroscience, and pharmacology. Her current positions are professor of anesthesia, professor of neuroscience and pharmacology, and she is the vice chair of research in the Department of Anesthesia. She earned her Bachelor's of Science in Biochemical Pharmacology at the State University of New York at Buffalo, PhD in pharmacology from the University of Illinois at Chicago, and postdoctoral fellow in neurobiology of pain at the Mayo Clinic in Rochester, Minnesota. With all of that said, it's my pleasure to welcome Donna. Thank you for joining us.
Thank you for inviting me. I will now go about to share the screen. Hopefully this will work for everybody. Okay, and here we go. Okay, why is it share? There we go. And there we go. All right. So what I'd like to discuss with you today is living with chemotherapy-induced peripheral neuropathy. Before I start, I'd like to sort of give you a few disclosures and other cautions. So first of all, I'm a PhD. I'm not a physician and I don't provide clinical care. So as we talk today, I don't want you to take my comments as any endorsement of any device or drug. My goal here is to just give you some more information that you can take back to your physician for further discussion and elaboration. At the end of today's talk, I will be describing a clinical trial that is underway at the University of Iowa using a nutritional supplement called Niagen. Chromadex is the manufacturer of Niagen, and they are making it available to us free of charge. I want to emphasize I do not have any other financial arrangements with Chromadex other than that. I also own stock in Merck and Novartis, but I will not be talking about any drugs that they manufacture in this talk. So my objectives for today are fourfold. First, I'd like to go through the signs and symptoms of chemotherapy-induced peripheral neuropathy. Second, I'd like to give a brief overview of the mechanisms of CYP-N, as we call it, shorthand. Talk to you about the treatment recommendations right now in the United States, and then walk through some of the approaches that are currently under study that may be fruitful in the future. So starting with the signs and symptoms of CYP-N, People who have CIPN will experience pain, burning sensations, strange tingling, pins and needles. Sometimes it's electric shock like. On the other hand, there may be numbness, and sometimes there are changes in your sensitivity to heat and to cold. Some people experience weakened reflexes. Others have what we call autonomic symptoms. They may find it difficult to empty their bladder. If they stand up quickly, their blood pressure may go up or down, causing dizziness or heart racing. Men may also experience erectile dysfunction. Some of the characteristics of CIPN are that it's symmetrical. So you'll see here in the purple, it's in both the right and the left hands. It initially appears distally, so by that we mean the fingertips and the toes. But as treatment goes on and it progresses, it begins to move more proximally, so up past the ankles to the calves, past the fingertips, into the forearms and the wrist. It often will worsen as treatment continues. And for people that are on platinum compounds like cisplatin, sometimes it will actually worsen 2 to 3 months after the chemotherapy ends for reasons that we still don't understand. So those are the signs and symptoms. But how does this affect the quality of life for your loved one, for yourself? So these are some examples just to give you an idea how life changes for individuals with CIPN. Oftentimes you are not able to grab a can of soda from the refrigerator because even though it's cold normally, for individuals with CIPN, it can actually be painful. So they have to wear gloves to insulate their hands. Many people eventually will lose the ability to drive because they just cannot feel the pedals anymore. Dropping a pin or a needle on a table can be challenging to pick up because you just cannot feel it, discriminate it from the tabletop. People begin to change the clothing that they wear. They may go to shirts that they can, or dresses they can pull on over their head because the changes in your fingertips and the sensations make it difficult to feel the buttons or the buttonholes. And finally, walking can become difficult and they need to rely on walkers or even wheelchairs if it becomes pretty bad. So you can see this fundamentally changes quality of life. Now, unfortunately, peripheral neuropathy is a side effect of almost every type of chemotherapy. In a little bit, we'll review some of the mechanisms of action, but they differ. We have many different approaches to killing cancer cells now, but yet peripheral neuropathy is almost a uniform side effect. Now, there are some differences between the chemotherapeutic agents. Some will affect sensations more. We call that more of a sensory neuropathy. Others will have less sensory effect, but affect motor function like reflexes and strength to a greater degree. Survey studies tell us that nearly 7 out of 10 patients will be experiencing CIPN at the end of their therapy. Usually, over the 6 months after the end of therapy, the percentage with CIPN decreases to about 30%. But in those 30%, it can last for years. So I have this line drawn here because for me, it reflects a change in how we've been thinking about CIPN. Before we had significant advances in cancer treatment, the attitude was that this was something that the patient just had to tolerate, had to power through to kill the cancer cells. Plus, it wasn't seen as such a big side effect because oftentimes people's lifespans were shortened. But now we've had so many significant advances in treating cancer, personalized care, new approaches, that the result is that the number of people surviving cancer and living fruitful lives with cancer has increased. So now this issue of persistent CIPN is increasingly important, and it's recognized as a significant unmet need in healthcare. So in this next slide, I'm showing you a graph from the National Cancer Institute that shows how cancer survivorship has increased. This is cancer prevalence and projections going out to 2040. Back in 1975, maybe 3.6 million people survived cancer. As of 2019, in the United States alone, nearly 17 million cancer survivors. If you think 30% of those have CYP-N, we're looking at numbers of about 5 million people have survived cancer and treatment, but have CYP-N. By 2040, we think those numbers of cancer survivors will go up to 26.1 million. So dealing with CYP-N and cancer survivors has now garnered much more attention and the importance that it should have. So let's turn a little bit to the mechanisms of CYP-N. I'm going to try to work off of schematics and keep it as straightforward as possible. It's by no means as simple as shown here, but I want to help you understand how it is that some of the agents that kill cancer cells are also affecting your sensations and your motor abilities. So on the left here, we have a hand, and it shows that there are some nerve fibers that have their endings in the fingertip that send long axons that terminate in the spinal cord. We call these primary afferent neurons. Primary because they're the first neuron in the pain pathway. Second, afferent because they are sending information into the spinal cord. It's an incoming pathway. Now, those that respond to painful tissue damaging stimuli, we call nociceptors, and they're of small size and a specific category. Others that respond to light touch, like brushing a feather across your hand, are larger in size. They respond specifically to light touch and non-tissue damaging stimuli. They also have their cell bodies in this structure called the dorsal root ganglion, and they send their endings into the dorsal horn of the spinal cord. Now, at this point here in the spinal cord, they make synapses or physical connections with a second set of neurons that has very long axons that go up to higher centers of the brain. These synapse on more neurons that then send their projections to areas of the cortex. So we have the perception and the cognitive effects of pain occurring in higher centers of the brain. We have important points of transmission where you can interfere with the transmission of pain information. And one of those very important ones is right here at this first connection between the primary afferent neuron and the neuron in the spinal cord. We now also understand that there's a different category of cells called glia that lie in close apposition to neurons. And in fact, they communicate back and forth with one another by releasing substances that bind to receptors that cause changes in how the neurons are activated and how they respond, and the inverse for the glia. So because most chemotherapeutic agents do not penetrate into the spinal cord or the higher centers of the brain, because there's a protective barrier called the blood-brain barrier, most of their effects are thought to occur out here in the peripheral nervous system, in the area of the primary afferent neuron. So in this next slide, we're just going to magnify, and what we're looking at here is that primary afferent neuron. It has its cell bodies in the dorsal root ganglion. It has long axons that then terminate, let's say, for example, here in the skin. On this slide, we can see a variety of different types of chemotherapeutic agents and where they can act. So let's start with the taxanes like Taxol or Abraxane. These act on microtubules and stabilize them so they can't function anymore. That means that substances that are made in the cell body that need to be transmitted all this way down to the terminals so they can stay healthy can no longer make that path. And this results in the terminals here beginning to malfunction and actually die back from the skin. This might be responsible for some of the numbness that people report with neuropathic agents, with chemotherapeutic agents. Platinum compounds like cisplatin and cyclophosphamide, which is an alkylating agent, they actually will bind to the DNA in the nuclei of these neurons and actually cause cell death. Then we have other compounds, also platinum compounds, and the taxanes are thought to interfere with the ion channels that are responsible for conducting nerve impulses from the peripheral endings into the spinal cord. We have checkpoint inhibitors, and we have some new inflammatory modulators that affect the glial cells that interrupt communication. So some of the mechanisms that the cancer-killing chemotherapeutics are doing is they're causing axon degeneration, dying back of the terminals of afferents. They can cause these primary afferents to die with cell death. They can activate inflammatory cascades that sensitize the primary afferent, making them much more excitable and more reactive to stimuli. And then they can also activate neuroimmune interactions. So as you can see, many different mechanisms, all of them involved in killing cancer cells, but they also affect neurons in the peripheral nervous system. Now, let's move to some of the recommendations that we have for treatment for CIPN. American Society for Clinical Oncology has published 2 position papers on CIPN, one in 2014, one in 2020, and they're listed here if you'd like to read them. I'm relatively new to this field, having started this work about 6 years ago. And what struck me with the 2020 paper is that it has been 6 years and really virtually nothing has changed for the treatment of CIPN. And that is the sad part of the state of research. But that is complemented by the fact that more and more people in my field are turning their attention to this problem. So let's talk about the current recommendations for treating chemotherapy-induced peripheral neuropathy. I've broken it down into 3 different approaches. First is, what can you do before chemotherapy is initiated? What can be done while you're receiving chemotherapy? And what can be done after chemotherapy ends and after you've completed your therapy? Now you'll see I have a subtitle here called evidence-based. There are many studies in the literature that are done in small numbers of patients. We now know that studies done with small number of patients have an increased likelihood of reaching false conclusions about effectiveness. You're more likely to get a positive outcome. And when those studies are used as evidence to support larger studies with hundreds of people, oftentimes that positive finding doesn't replicate. Evidence-based means it can be replicated by several research groups, that there are appropriate controls, and especially in pain research, that's important because people in pain have a very high motivation to get better. So people who receive placebo-controlled treatments in pain trials, as many as 30% of them can report improved relief, and they've only received the placebo. So this makes it difficult to detect a true positive beneficial effect. We're also looking to see that patients have been randomized between the treatment arm and the control arm. And we prefer to see that the people assessing the outcome are blinded, so they aren't biased to make decisions about data that they can include or not include. So we're really looking for large, randomized, placebo-controlled trials. Right now, before chemotherapy, no agents are recommended. In fact, one drug that went to trial based on preclinical data and a small clinical trial was acetyl L-carnitine. We now know that in the first trial, it actually worsened the CIPN in the patients who were on it. And a follow-up trial 2 years later of those same patients showed that they still were experiencing worse CIPN. So right now, absolutely nothing is recommended for starting before chemotherapy. During chemotherapy, there are no agents that are currently recommended to deal with the CIPN as it evolves. What can be done is to delay or reduce the dose that you're receiving. Sometimes you can change the chemotherapy. Or at worst, if the neuropathy or the functional impairments are intolerable, you may actually stop chemotherapy. I don't have to tell you that these three options are not optimal options because each one of these carries with the risk of dealing with the neuropathy also means less cancer cell killing ability. After chemotherapy ends, there is some good news that an antidepressant called duloxetine was found in a clinical trial to be of benefit in treating CIPN. That is, one advance that was first floated in 2014 has now been confirmed in a couple more trials. Unfortunately, it seems to be effective only for platinum compounds, and the emotional well-being of the patient seems to be a predictor of efficacy. So let me now move to updates on what can be done, what's under study, things that you can be looking forward to, looking on clinicaltrials.gov for studies that you might be able to participate in. So, and I know of particular interest are approaches that you can take that don't involve drugs, that are more in lines of complementary and alternative or integrative health approaches. So there's been a study that came out of a specific exercise routine that can be done at home over a period of about 6 weeks. And that trial supported a very small reduction in the severity of the CIPN for prevention of CIPN before therapy started. So you would be doing it as you started your chemotherapy regimen. Based on this data, the National Cancer Institute has approved the concept of conducting those critical, large, prospective, randomized controlled trials. So this is something to be on the lookout and to sort of discuss with your physician as maybe something that you can be incorporating in your daily activities. For persistent CIPN, that which persists after chemotherapy ends, I'm going to go into detail about the duloxetine data so that you have a good understanding of that. And then we're going to touch on what we know about cannabinoids, acupuncture, scrambler therapy, and then I'll touch on a nutritional supplement that we're doing a clinical trial on here at the University of Iowa. So let's take a look at duloxetine. So duloxetine acts at a specific set of pathways. So on the right here, I have a schematic. Out here, we have the feather activating the peripheral afferents, primary afferents. They're in red. They're coming in here to the spinal cord. They synapse on these ascending neurons that then go up to the thalamus and the cortex. So that's your ascending pain pathway. We talked about how this is probably one of the first sites that you can interfere with the transmission of that information from the periphery into the central nervous system. And it turns out that we have what we call descending pain modulatory pathways. They're sketched out here in blue. These are pathways that you can access through biofeedback, through hypnosis, through different types of psychotherapy. And they appear to, and also some analgesic drugs activate these pathways. They end up in releasing substances, serotonin and norepinephrine and enkephalin right here and this synapse. So you see I have a triad right here of the cell body, the red pain pathway coming in, and the blue pain inhibitory pathway, all synapsing here in one area. So this is where we think duloxetine may be acting. And how is that? Well, it turns out that duloxetine, which is marketed by Eli Lilly under the name Cymbalta, actually is a serotonin and norepinephrine reuptake inhibitor. So recall that I said that these descending modulatory pathways are releasing serotonin and norepinephrine and enkephalin right here in this connection between the primary afferent neuron and the spinal cord neuron. Over here on the left, we can see that serotonin or norepinephrine is being packaged in the nerve ending. It's then being released into the synapse. And once released, it can act on receptors that can then, in this case, inhibit the dorsal horn neuron so it becomes silent, so it can't transmit the pain information. So if you can increase the amount of serotonin and norepinephrine in this synapse, then you can achieve greater silencing of these neurons. And that's what duloxetine does. Duloxetine inhibits this mechanism for sweeping the neurotransmitter up out of the synapse. And so by blocking that and preventing its being taken back up, it means the serotonin and norepinephrine are present in the synapse at higher concentrations for longer periods of time. That gives you greater inhibition of the ascending pain pathway. So that's exciting. What does it look like? So in cancer survivors, this is the first study that reported out the effect. It meets our criteria for evidence-based. 231 subjects, they received either duloxetine or the placebo for 5 weeks, and it was a randomized clinical trial. So on the y-axis, on the left side, we see the percentage of patients. And on the x-axis here in the bottom, we see the percentage of pain reduction. So about 0 means there's essentially no pain reduction. 50% means that pain was reduced by about 50%. 100% means they had stellar relief. So how do you read this graph? Well, first you select a percentage of patients. Let's say you want to know what happened to 40% of the patients. Then you draw lines down. So for the placebo group here and the red squares, only 40% of people in the placebo group achieved a 10% pain relief. In comparison, those in the duloxetine group, 40% of them achieved greater relief on the order of about 25%. Now you can do the same thing and expand it out to what percentage had, for instance, 60% pain relief, only 5% of the placebo compared to 10% of the duloxetine treated. So going forward, then the study investigators were, that's a small effect. Let's be honest, it's a small effect. So because the patients on this study, some of them have been receiving drugs like cisplatin and others have been receiving taxanes like Abraxane or Taxol, they separated out the patients by chemotherapy. And to their surprise, they found that the duloxetine was actually reasonably good in patients on the platinum compounds, but those on Taxol and Abraxane weren't achieving any benefit. So this is a small effect. And so the next question is, how does that compare to duloxetine's use for other chronic pain conditions? And here they added in what they knew about its effects in painful diabetic neuropathy, in fibromyalgia, and in treating osteoarthritis, and then this trial as a whole. And as you can see, its pain relief for CYP was comparable to these other chronic pain conditions. So this was good news. And it's been now replicated in 3 smaller, more recent trials. So now ASCO is fairly confident in suggesting that physicians should be trying duloxetine in their patients with persistent CYP. Do have to understand that the effect was small in size. It's about a change of 1 on the pain scale, but any lessening of pain is something we seek. Really will be of little use for people on the taxanes, was limited to people on the platinum compounds, and also those who have better emotional well-being, and chronic pain is something that's very difficult to tolerate with emotional well-being. They seem to do better in achieving pain relief with the duloxetine. So now the recommendation is trying duloxetine in patients who have persistent CYP based on platinum compounds. Now you may find that your physician wants to start you on other drugs like gabapentin and pregabalin. In fact, some insurance companies are expecting to try gabapentin and pregabalin. The fact is that the data do not support their efficacy in treating CYP. And in fact, in many of the patients who are enrolled in my current trial, they are on gabapentin, but the reason they can qualify for the trial is because they're still experiencing CYP. So this is something to have a discussion with your physician about, or your insurance company if they ask you to do the gabapentin first before paying for the duloxetine. So I'm betting at least half of you are asking about cannabinoids and CYP-N. And I have to say that it's wishful thinking. I'm not going to diminish anecdotal reports or people's individual experiences. But from my viewpoint as a scientist, what I see is that now that medical marijuana has been legalized, we have a situation where the population is embracing a treatment in the absence or before there is strong clinical evidence of its efficacy. In fact, of the trials that have been done, those done during while people were receiving chemotherapy, actually it turned out to be not a good thing. And so there's actually intermediate level evidence against its use for those who are receiving chemotherapy. There's really no recommendation for its use for persistent CYP-N. And in fact, when I went through clinicaltrials.gov looking for trials on cannabinoids and CYP-N, I could only find 2 that were registered. The other supporting data for why I think this is wishful thinking is a systematic review that was published last year in the journal Pain. This is the preeminent journal in my field. And what they did is they reviewed all clinical studies that have been done of cannabinoids for any type of acute and chronic pain management. Not surprisingly, there were many studies, many small studies, but the overall quality of the evidence was considered to be low. There was also evidence of high bias. And finally, many of these studies did not adhere closely to the consort guidelines. And these are guidelines that dictate how you design a really good randomized controlled clinical trial. So at this point, ASCO would not be recommending cannabinoids for the treatment of CYP-N. From a preclinical standpoint, in my field, this little schematic down here in the lower corner shows evidence for why we would think cannabinoids should be effective. They can impact microglia and neurons, but what's seen preclinically does not always translate to clinical trials. So at this point in time, this is the status of current thinking on using cannabinoids. So let's turn now to acupuncture. Acupuncture is safe. It's a non-pharmacological approach. It's complementary and alternative medicine. A new term for that now is integrative health. And although at present there are no large randomized controlled trials, there is intriguing data in the clinical literature. Now, some of the challenges for putting this all together into a strong recommendation are listed below. There are many different types of outcome measures, and so there's no standardized outcome measure. So many of the trials that have been done use different outcome measures. There are different types of acupuncture. It can be manual stimulation or it can deliver an electrical current. The location and the dosage of acupuncture vary between studies. The numbers of subjects are often low. Sham controls may not be included. And part of that is sham controls would be trying to come up with an approach that you could give the patient that would blind them to whether they were receiving acupuncture or not. When you're receiving acupuncture, it's actually a bit uncomfortable. And so it's difficult to blind subjects to whether they're receiving the acupuncture or not. So this is a sort of a challenge. And we don't have any systematic studies that have sort of a block that have looked at how it works at preventing, and a block and how those have looked at the treatment during developing CYP-N versus those that have looked for relief of persistent CYP-N. But I will show you a few snapshots of data here. There is evidence in the literature of efficacy. The study here on the left is out of Hong Kong. One of the problems is it's only 28 people in the treatment group. And they broke it into those that had received or finished their chemotherapy, and they either received acupuncture or they were in a control group where they were waitlisted to take part in the study. So that was sort of the natural history of the persistent CYP-N. compared to a group that was being actively treated with the acupuncture. And what they saw in the diamonds here is that over a period of 8 weeks, there was a significant reduction in the pain score in those patients, and it continued out through 14 and 20 weeks. Now, it's a small effect, but it was not a poorly done study. Recently, 2 papers were published doing what they call a meta-analysis. Meta-analysis is an approach where you review everything that's ever been published in the clinical literature about acupuncture and CIP-N. Then you sort through those studies and you look at how well they were done. Are they low quality, moderate quality, or high quality? And then what's the total number of subjects that were tested? And then you integrate those findings into a summary. As it turns out, for all the studies that have been published, there are only 6 high quality studies, but they totaled 386 patients all told. Those studies collectively reported a significant improvement in pain, so about a 20% improvement in pain. And then using another assessment tool called the Functional Assessment of Cancer Therapy, which is more functional than just pain scores, they actually found an odds ratio of 2. So there was a very clear benefit of acupuncture in these patients. And this graph down here in the bottom left shows you the FACT score and then the scores for the intervention in diamonds or the control waitlisted group in circles. And we can see that those that were in the intervention group had significant improvement in their functional scores of pain. Right now, there are 22 trials in clinicaltrials.gov of acupuncture and CIP-N. So I would expect that we're going to, in the next 4 years, have more information on its efficacy, and we will be seeing more higher quality studies. Now, how is it that we think acupuncture might be working in painful CIP-N? As you recall, I mentioned that the primary afferent fibers express a variety of channels. These are channels that allow various ions to enter in or leave the neuron that let the electrical impulse flow down the nerve into the spinal cord. They also express a variety of other types of channels, and one of these important ones is TRPV1. Now, TRPV1 is an interesting channel because this is the channel that the ingredient of hot peppers, called capsaicin, activates. It's also the channel that activates in response to very hot temperatures, heat pain. So this is a channel that integrates a chemical painful stimulus and a heat pain stimulus. And so when these channels are activated, these ions flow in and your sensation is pain. And if you want to think about that, if you've ever eaten hot peppers and then wiped your eye by accident, that burning pain is TRPV1 mediated pain. So the sensory afferents that convey pain, they express these TRPV1 receptors. There's also an immune receptor called toll-like receptor 4 that when it is activated, it sensitizes the TRPV1 receptors. It makes them more excitable, makes them more responsive to heat and capsaicin and sometimes pressure. Well, it turns out that paclitaxel, taxane, Taxol, and Abraxane actually activates the TLR4 receptor. It binds to it. This is new information. And when you activate the TLR4 receptor, you end up increasing the number of TRPV1 receptors that are expressed by the primary afferent. That's a means of amplifying or increasing the gain of the signal. So now we think that some of the acute pain that people experience after paclitaxel infusion and some of the chronic CIP-N is due to sensitization of these TRPV1 receptors. And there are a few studies out now that suggest that how acupuncture works is that it blocks the signaling through the TLR4 receptor. And when it does that, it prevents sensitization of the TRPV1 receptors, all in all, turning down the gain. So showing you a little bit of data here. On the left, this is a recent study that was published. They treated animals either with nothing or they gave them paclitaxel in the red bars. Then they had animals that they gave paclitaxel to, and they did electroacupuncture. So this was done in rats. Then there was a group that they did paclitaxel and sham electroacupuncture, where they just place the needles and maybe they twiddle them, but they don't run any electrical current. So the red bar is higher than the black bar. So that showed that paclitaxel increased the number of primary afferent neurons that responded to capsaicin. So there's that sensitization. The blue bar is significantly lower than the red bar. So it showed that when they did electroacupuncture, the number of sensory afferents that were sensitive to capsaicin was significantly diminished and really didn't differ from the control situation. And here, the important sham group, where there was no electroacupuncture, didn't differ from the paclitaxel alone. Over here on the right is something that we call a Western blot. And these black bars here are a way for us to visualize the amount of protein. So the thicker the bar, the darker the bar, the more protein. So I'd just like you to look here in the first band, that's the TLR4. You can see in the control group, there's expression of TLR4. In the paclitaxel group, this band is much thicker and darker. So the paclitaxel has increased and activated the amount of TLR4, which is resulting in more TRPV1 channel expression. In the presence of electroacupuncture, this bar now is pretty close to what it was in the control values. It's decreased the amount of TLR4 signaling, and at the same time, we had a reduction in the TRPV1 channel expression. So this is a current hypothesis about why it is that acupuncture is effective. So to wrap up acupuncture, it's safe, it's non-pharmacological, integrative health approach. Data are accruing in support of this. I do want to be clear that it shouldn't be confused with dry needling that is used by physical therapists for myofascial pain. It is very distinct from that. And you may be thinking about TENS. TENS is a different way of delivering electrical stimuli. It has a different mechanism of action. And unfortunately, there's no strong evidence for the efficacy of TENS in treating persistent CIP-N. So something that is new on the horizon is called scrambler therapy. Now, a picture of this is up here in the upper left-hand corner. We see a subject. She's set up with electrical electrodes sort of placed over here over her wrists and around her ankles. She's suffering from CIP-N and over here on her feet. And the idea here is that you're applying rapidly changing electrical currents to the same nerves that are conveying pain. So the idea is that you're actually scrambling the transmission of pain information. So what arrives in the spinal cord is garbled. This is, again, different than TENS. And I'm showing you here a very small pilot study out of the University of Michigan because this group specializes in clinical studies of CIP-N. And it's this type of pilot data that we can be excited about, but we also need to be cautious about. But down here on the y-axis on the left, we're seeing the percent change in the symptom score. And these were people that came in for 14 days straight to receive the scrambler therapy versus a control group that they did TENS on. As you can see, over time, the TENS did not change the pain score, symptom scores in these patients. However, the scrambler therapy with time at about days 5 or 6 caused about a 20 to 30% reduction, and later on, apparently an even greater reduction in the symptom scores. So that was exciting. This group does very comprehensive studies. So the other thing they did was just not look at pain studies, pain scores, but they looked at some of the quality of life indicators. So here we look at the global impression of the change for neuropathy. And you can see that the TENS in the dark blue stayed about the same during the 14 days and continuing on after the scrambler therapy stopped. The the teal colored scrambler therapy almost immediately made people feel a little bit better with respect to their neuropathy and finally moderately better. Similarly, the impression for change of pain was better than 10s, and for quality of life was better than 10s. So some of the things to look at here is, on day 1, there was a significant effect already of the scrambler therapy. That's a bit surprising. That's what the patients report. Again, we want to be cautionary. At the same time, the people with 10s did not report a placebo effect, and again, didn't report a change here. So this is a new therapy that is available, something you might want to discuss with your treating physician. And of course, we're going to be waiting for those large prospective trials to come out. I did not get a chance to see what is ongoing in clinicaltrials.gov. Definitely would be worth looking for. Lastly, I'm going to finish up touching on nicotinamide riboside. This is Niagen. It's marketed as True Niagen by a company called Chromadex. You may know it as a nutritional supplement. You can pick it up at Costco and at Hy-Vee. Nicotinamide riboside was recently identified as a third form of vitamin B3. So it's a naturally occurring different form of vitamin B3. Turns out that when administered to animals and people, it actually makes its way into the pathway that synthesizes nicotinamide adenine dinucleotide, or NAD. NAD is a very important component and necessary for all energetic reactions in the body. So lower NAD, less substrate for fueling energy reactions. In preclinical studies done in mice and rats, studies found that if they modeled construction noise-induced hearing loss, think of construction sites, jackhammers, in mice, that treating them with the Niagen would prevent the damage to the cochlear afferents and hair cells. In models of diabetic mice, and people with diabetes develop both a loss of heat sensation and they become exquisitely sensitive to touch, Niagen treatment in the diabetic mouse prevented these signs and symptoms in the mice. Finally, my lab has shown that in models of paclitaxel or cisplatin induced peripheral neuropathy in rats, that both treatment before with Niagen and treatment after with Niagen can reverse the signs and symptoms of this CYP in rodents. I'll show you just a little bit of what those data look like. I don't want to forget, right now, to be honest, we think that the ability of Niagen to act is due to its ability to increase NAD, and it corrects the dysfunction of mitochondria. Mitochondria generate energy for cells, but this has not yet been proven. There's also a growing indication it may have some anti-inflammatory activity. But right now, these are hypotheses, they are not knowns. So a little bit of data from our lab. These are rats that we had treated with paclitaxel at a dose that produces plasma concentrations similar to what people experience. And we started out by getting baseline values of how much pressure did we have to apply to the hind paw before the animal would withdraw it. And our maximum here was 15 grams. That's not a lot of pressure. So before paclitaxel, our animals that were treated with the vehicle as control or with the Niagen did not respond to light touch. 14 and 21 days after giving the paclitaxel, you can see the animals are now exquisitely sensitive. So the bars show the average data and the symbols show the values from the individual rats. At 14 days, the animals that received NR showed a slight improvement. They weren't quite as sensitive to the touch as the vehicle treated animals. But by 21 days, so this is something that takes time, over half the animals were no longer sensitive to the light touch. The rest had greatly reduced responses to light touch. So this looked like it relieved the sensitivity to light touch. Cold is also problematic sensation for people with CIFN. So in those same animals, we put sort of a cold stimulus under the hind paw and measured how long it took them to pick their paw up and walk away. Usually it takes about 22 seconds. 2 weeks after paclitaxel and 3 weeks after paclitaxel, we can see that the animals now are withdrawing much more quickly, more rapidly, at about 16 seconds. But the animals that received the pre-treatment and continued treatment with NR didn't differ from baseline values. There was a significant reduction in their sensitivity to cool stimuli. Another piece of data that I'd like to share with you had to do with our initial probing into what would the mechanism of action be. Earlier, I had touched on the fact that drugs like taxane are microtubule stabilizers. That means it makes it difficult for nutrients and other things that need to get down to the peripheral terminals in the skin to be transmitted down there to maintain the health of the terminals. And we see what we call a dying back. The terminals of these neurons begin to retract from the skin. So in animals that we had established with breast cancer model with just the tumor, we used immunohistochemistry, which is a way to visualize the nerve endings. And so right here, these little white strands that you see, we're actually visualizing the endings of the sensory primary afferents in the skin. And they're fairly well organized. But in animals that have been treated with paclitaxel, they have a shattered appearance. We don't see very many of those nice long structures emanating up towards the skin. There's fewer of them and they're shattered. In animals that we had treated with NR, we were very excited to see that it prevented this loss or dying back of the intraepidermal nerve fibers. And again, we can see this looks much more like the tumor control than the paclitaxel treated animals. And on the left, we're just showing the actual counts of the numbers of crossings in the 3 different treatment groups. So this suggests that NR may prevent the dying back in taxane chemotherapy. So these data were used to submit applications to a number of granting organizations. They were received enthusiastically. I'm just going to discuss one with you now. This is graciously funded by the V Foundation, Victory Over Cancer. It's entitled Niagen for the Relief of Persistent CIFN in Cancer Survivors, and its clinical trial number is listed here on the bottom. It's placebo-controlled, double-blind, and randomized. So our subjects are being randomized into either receiving a placebo capsule or the Niagen. They're blind to what they receive. I'm blind to what they receive. So we can't introduce bias anywhere here. We're looking for people who are cancer survivors. They can have had breast, head and neck, sarcoma, small cell lung, gynecological or colorectal cancers. Completed their chemotherapy more than a month, but less than or 15 months after the final dose at the time of enrollment. Those on the treatment arm take 500 milligrams of Niagen daily, twice daily for 12 weeks. They come into us every 2 weeks. We take a blood sample because we want to measure levels of NAD in their blood. They fill out a quality of life questionnaire, and this is important because quality of life questionnaires are you telling us what you think about your neuropathy and its impact. We also have a physician score neuropathy, and there are differences between how physicians score neuropathy and their interpretation and what the patient's experiencing. So we've incorporated 2 measures here. And also, a lot of people on chemotherapy, it's oftentimes, it's just now being appreciated, have sensations of grittiness and dryness in their eye. So we added in a dry eye questionnaire because that decreases quality of life as well. At the beginning of the study, in the middle, and at the end, we take a small skin biopsy and we're looking to trap those fibers in the skin, in this case, the small ones that convey pain. And we also use a fancy confocal scanning microscope to scan the fingertip to look for a structure called Meissner's corpuscle, which is attached to large diameter fibers that carry sensations of vibration and light touch and things like that. And we're looking to see, is the Niagen treatment not only affecting the patient's quality of life, but can we understand better maybe how it's affecting a potential mechanism? This study was delayed a year by COVID. We've just started enrolling this year. I think it will be going for at least another year. We're really recruiting hard. The problems as far as having people enroll is you have to be able to make the drive to Iowa City every 2 weeks for a short visit. You get paid $20 for every visit. Unfortunately, we haven't worked out a way to be able to do these studies at more remote locations, but it's something I'm giving my attention to. So finally, I'm happy to take any questions. Before I do, I want to thank you as a taxpayer and as donors to various organizations, because you have helped me conduct both the basic science and the clinical research here. I'm a member of the Holden Comprehensive Cancer Center. They've been very supportive of this work, and I'm not a cancer biologist. I'm a neuropharmacologist. The National Cancer Institute has funded some of my research. The National Center for Complementary and Integrative Health has funded the research, and so has the V Foundation. Thank you so much for your support and for your attention. And now I'll stop the share.
Thanks so much, Donna, for that wonderful presentation. We have a few questions. Is peripheral neuropathy a permanent condition, and does it worsen over time?
So for about 30% of patients who develop peripheral neuropathy, it can become permanent. There's a period of about 6 months, so 70% will experience it ending therapy. It will subside in numbers, but about 30% will still have it at the end of 6 months. And it can last for years in people. And I think there was another part to the question.
And does it worsen over time?
Okay, it doesn't worsen over time with the exception of drugs like cisplatin and oxaliplatin. It will worsen 2 to 3 months afterwards. I'm not sure if it stays at that worsened state or if it then subsides. That's a phenomenon we call coasting. We don't understand what it is. But the thing about platinum compounds is the platinum actually enters into the nucleus of the cells and it binds to the DNA and it stays there. It doesn't get flushed out or anything like that. I hope that answered that question.
Yes, thank you.
Okay.
And I'm going to make a request before I get to the next question. So there's a participant on with the initial PB. Your question did not come through. If you could send it again, that would be great, and we'll get to that. Our next question is, does walking regularly help the peripheral neuropathy?
I think that that one study that I talked about, there's actually, and I have my email on the first of the slides. Don't hesitate to reach out to me. I can give you the reference for that. The National Cancer Institute has actually developed an exercise regimen that you can do at home for about 6 weeks. I haven't had a chance to look at that to see how much walking it entails. And of course, walking can be difficult with CIP-N, but this is one of those sort of safe therapies that I don't see how walking can be bad for you, but definitely discuss this with your physician. And I'd be happy to direct you to the exercise regimen and some more information that you can share with your physician on that.
Thank you.
One thing we are finding outside of CIP-N, but in chronic pain, is that exercise can help mitigate chronic pain. So for CIP-N, the jury is still out, but we're investigating it.
Can peripheral neuropathy be misdiagnosed as something else for patients? Is there things that patients should be looking for? Because oftentimes, is this a condition that may be misdiagnosed as something else?
Okay, so there are different types of peripheral neuropathy. To be diagnosed with chemotherapy-induced peripheral neuropathy, you must have been administered a chemotherapeutic agent. Without that, you cannot be diagnosed with chemotherapy-induced peripheral neuropathy. However, you can develop peripheral neuropathies from metabolic situations like diabetes, from treatment for HIV, alcohol overuse can cause peripheral neuropathy. There are genetic neuropathies that can be inherited that can develop, like Charcot-Marie-Tooth, which is actually also being studied here at the University of Iowa. So a visit to a neurologist would be very helpful in helping to sort out any of those possibilities. Also, frank nerve injury, like let's say you drop a hod of bricks on your foot, auto accident with brachial plexus avulsion. There are many types of actually frank nerve injuries that can result in peripheral neuropathies.
Thank you so much. And this says, thank you for the superb presentation. I was diagnosed with cyclosporine-induced peripheral neuropathy, expressed as lower extremity movement disorder. Are there parallels between chemo-induced peripheral neuropathy and cyclosporine-induced peripheral neuropathy?
I would say they're one and the same. So cyclosporin is not only an immune suppressant, but it binds to DNA. It is a type of chemotherapy. So sometimes when I present my research, when I'm talking about the animals I've given paclitaxel to, I'll use the term paclitaxel-induced peripheral neuropathy. Chemotherapy is sort of a generic term. It covers all the different types of chemotherapy. So in your case, the cyclophosphamide is a chemotherapeutic agent, has an additional immune suppressant component of action. So you do have, I would say, chemotherapy-induced peripheral neuropathy.
Well, thank you so much for the wonderful presentation today. And hold on one moment. We had another question that just popped up. So let's go ahead and answer this.
Sure.
No significant CIPN after transplant. And then a year later, they had bad arm tendonitis and feet. Looks like they had a week of gabapentin. Then 2 years later, came back. Now they're on 60 milligrams of the is it duloxetine?
Duloxetine or Cymbalta.
Taken in the morning. Works great, but problems at night while they're sleeping. They're currently taking 40 milligrams in the morning and 20 at night with no help. Any ideas?
Oh, that puts me into the world of being a physician, which I'm not. I'm delighted to hear you've got relief for the pain, the consequence problems, attendant problems with sleep. I can't comment on. So I'm glad you've been able to obtain some relief, but there's nothing more I can say without being like totally out of my wheelhouse. So
talking to the treating physician is the best thing to do at this point.
Absolutely. Yes.
All right. Well, thank you so much, Donna, for sharing your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our program today. Thank you again, Donna.
Thank you.